A fourth-generation pharmacy owner known as the Drug Cowboy, Arkansas Health Bill 1150, in a conversation with APCI from our PBM Reform podcast, and pharmacogenomics in the impact to testing, as well as the complexity of specific medications that could prove to be a major issue for people's health. All of that coming up on This Week in Pharmacy. Welcome to This Week in Pharmacy. I am your host, Todd Urey, founder of the Pharmacy Podcast Network. I hope you've had a good week. Just got done with our crazy Halloween special. Hopefully you were scared. If you weren't, whatever. You don't have to be. Appreciate you listening. Appreciate you being part of today's TWIRx, November 7th, 2025. Hey, it's my mom's birthday today. Shout out to Joyce Delaire down in Vero Beach. Happy birthday, Mom. Hope you have a great day. Have to call my mom on her birthday. Hey, we have a lot going on. First up is going to be TWIRx news. And the first article that I am excited to talk about is the Binghamton. I can't say it. This is why I wasn't a pharmacist. Binghamton University. Goodness gracious. The School of Pharmacy holds emergency management simulations. And this goes through, hey, what if there's a major situation in your community? And how are you preparing for a major disaster, a pandemic? Being able to dig down into how emergency management would work with pharmacy owners, pharmacists, health systems, hospital systems. This is amazing. Shout out to the School of Pharmacy in really digging down into how to leverage pharmacy in an emergency time. Next up, I want to just make a shout out to VCU Health. VCU Health school they have a School of Pharmacy as well. But VCU Health is pharmacies are expanding access through a new home delivery option. We know that the increase of pharmacy at home, long-term care at home, this is major for the entire nation. But starting on November 11th, home delivery will be available from all VCU Health pharmacy locations in the Richmond area. This is not just a trend. This is going to become standard of care, where we'll have people that aren't able to get out of their home. They don't have transportation, or there's a pharmacy that's too far away from them. I see an expansion of long-term care at home, and this is wonderful to see from VCU Health. Shout out to you guys. Big news: Lilly and the U.S. government agreed to expand access to obesity medications to millions of Americans. This was just posted by Eli Lilly and Company on November 6th of this week, and it goes into announcing agreement between the U.S. government to expand access to obesity medications, and really marking a pivotal moment in the U.S. healthcare policy and defining milestones for people in need of obesity medications. This is good for the evolution of PBM reform, but good news from Lilly. It's good to hear that access is getting more attention from the United States government in what's happening, and pharmacists know firsthand when we have medication shortages and how compounders can step in, and how that's a big controversy in and of itself, with the manufacturers saying that they don't want compounding to rise when need be. And I think you need to be a player in it. And Lilly obviously is an immense and powerful player. However, when patients need customized things and additional medications that may not be available We have the compounders stepping in, and we're so proud that the APC, the Alliance for Pharmacy Compounders, is a member of the Pharmacy Podcast Network, and it's really a nice balance to have information from sources, trusted sources that are concentrating ultimately on services for the patient in the needs of the patient, instead of it being just about the business and just about the formulary and the customization of where that can take all pharmacy services, not just big box or community or health system, but all of them. And I just think there's something we need to pay attention to as a pharmacy care organization. And here at TWIRx, we want to pay more attention to what's happening. Hey, if you have success in obesity specifically, and you're a pharmacist, you're a independent community pharmacy, you're a clinic, we want to talk more about obesity. We did a multi-part series on the Obesity Chronicles that's out there. If you Google Obesity Chronicles Pharmacy Podcast, the 10-part series will come up. And it's an important, very scientific 10-part podcast series that you could update and listen to. We have a lot going on. We have several interviews today and several guests on the show. And we're going to start out with Amantha Bagdon from RxPost. And I can't wait for you guys to hear this on This Week in Pharmacy. Hey, and on This Week in Pharmacy, we talk about data. We talk about many things happening in the markets. We just got done with TWIRx news, good news, bad news, what's happening in our profession. I really am drawn to people in our profession who are passionate about this industry and what's happening in the transformation, but they take time to keep up with what's going on and apply their passions and their outlets, their talents, their experiences to improve in something. And an entrepreneur who rose, I don't know if it's been 12, 15 years, became a friend of hers and have looked up to her and her aspirations to keep pushing. Amantha Bagdon, I want to welcome you back to This Week in Pharmacy. Although I don't know if it's your first time or second time on TWIRx, but we got to get you here more often. Amantha.
Hey, Todd, it's good to be back. I know that we've had several encounters, so it's definitely hard to keep track. Thank you so much for having me back on the show, though.
Absolutely. You need to tell the listeners, because you're very inspiring as a woman leader in business, as a healthcare leader in general, where you've done things at a whole nother level with your background, and you started in pharmacy. You have to tell people a quick little story so we can bring them up to date to RxPost.
Yeah, I am a pharmacy technician. I've been a pharmacy technician since I was 16 years old, so more than half my life now. And I spent a majority of my career working at independent pharmacy and absolutely fell in love with the level of patient care that you get to experience every day with your customers there. And throughout my journey, I noticed how difficult it really had become for pharmacy owners to stay profitable. And I worked under a very smart entrepreneurial pharmacist myself, Greta Goldstein. She's now owns a pharmacy in Calabasas, doing a lot of really cool stuff on the point of care testing side of things. And when I was working with her, we struggled with excess inventory, and it was my job as the technician to call around to other stores. And sometimes that meant getting into my car during my lunch break and driving to another pharmacy and taking notes manually and just kind of putting Post-its everywhere. And that really led me to launch RxPost as an easier way to connect more pharmacies for inventory sharing. And it's been a long journey, but we've seen a lot of success, particularly in the last year or two. And now that we've gotten to 16 states in total, we're looking forward to some of the next things that we can do beyond just helping pharmacies save money. but also helping them generate revenue, but with a real focus on what's near and dear to my heart, which is the pharmacy technician and how to get them appropriately paid, which is a frustration I think that many of us share in the industry.
Yeah, there's a couple parts there. First of all, I want to back up, and there are pharmacists listening, there are technicians listening who have aspirations to do something that they've been doing, or at least I hope you've been doing it. And the reason why I say that is always have a side kind of hustle, whether that's your blog or your podcast or your passion, or it's something driven in technology or the use of AI and making it make sense within the business of pharmacy. Whatever that is, continue to pursue that. You did that alongside of your primary work as a pharmacy technician, and now you're running RxPost and growing RxPost, and you're meeting with investors, and you're delivering complex proposals, and you're working with banks, and you're working with insurance organizations, and you have a lawyer now. So it's what people are listening to at this moment, and having you on TWIRx is someone who transformed from being a pharmacy technician at, or in the pharmacy business at 16, became a pharmacy technician, and now you saw a void that was impacting your profession. It was also impacting independent community pharmacy, which is a soft spot in both of our hearts. So, what do you say to these people that are listening right now that are like, I want to build something, I see a void, I see something that I'm passionate about?
Yeah, I think it starts with micro adjustments, being very open-minded to coachability and learning from everyone around you. I think one of the key things is networking. I always tell early founders, network with as many other founders as much as possible, and find out, what the challenges they experience are. So hopefully you don't repeat the same mistakes, but it's never going to be an easy journey. But if it was easy, it wouldn't be worth it. And I think one of the things that keeps me going is a lot of the stuff I do on the advocacy side. So I'm on the board of 2 local pharmacy chapters here in Los Angeles. I've served on the reference nominating and policy committee for the California Pharmacists Association. Won California Pharmacists Association Technician of the Year last year, and was elected delegate for this upcoming year's American Pharmacists Association House of Delegates. And also going out there to the non-pharmacy stuff and bringing a lot of awareness to the space. I think it's always shocking when I talk to non-pharmacy people, and their first question or comment is always, "Oh, I didn't know independent pharmacies still exist." And I love coming back and saying, like, they make up 36% of all retail pharmacies. Like, they're nothing to sneeze at.
If you started to include some of the independent pharmacies that are embedded into grocery stores or other entities, I guarantee you that percentage would be higher.
It is. It's about 2/3, which are just not CVS and not Walgreens. And that used to include Rite Aid, RIP Rite Aid. Rite Aid was my first job when I was 16. So it does hold a special place in my heart, and especially because Thrifty ice cream started here in SoCal. I can't wait for whoever bought that Thrifty ice cream brand to bring their pop-ups here.
That's awesome. All right, so I have something to ask you. We both know what's happening in pharmacy. You and I have discussed this at other conferences. I'm not sure if it was Assembia or I met you. It was in Vegas where we sat down and talked for about an hour. And this might have actually been 2 years ago. Time goes by too fast. But we were talking about the void that's going to take place based on pharmacists being drawn into digital health, mapping disease states, being stewards of the entire therapy that the physician launched, specialty medications, specialty disease states. I could just keep going on and on. Pediatrics, it's so when that starts to happen, you have systems like iCare Plus, which is part of the IPC system. You have DocStation. You have all these systems. You have Prism, which is a brand new system for pharmacists. They're actually specific to birth control to start out, which is just amazing because of their specificity and expertise. All right, so that void takes place. It's going to happen. It's already happening. We have the business that's sitting there, the pharmacy business, sometimes the single business, sometimes 10 stores, whatever. Just like you, we have our technicians that have been sucked up into the business of running that pharmacy, keeping it profitable. There's all this data. Talk to me, because I just want the listeners to hear your passion. This is an exciting time to be an aggressive pharmacy technician that is ready to do things that techs haven't normally done in the past, and level up and make more money.
Yeah, and I do want to say I appreciate companies like DocStation, started by a pharmacist, Sam, and Scripted, started by a pharmacist, James. And I do think a lot of these solutions should be sold by insiders, and it's a very tight-knit community. But yeah, pharmacy technicians are kind of, as pharmacists move up in their roles at the pharmacy, doing more clinical services, what we see in states, particularly like Iowa and Idaho, that have expanded, standard of care models. Here in California, Governor Newsom just signed our standard of care bill, AB 1503, that very soon after, pharmacy technicians also kind of move up in that standard of care model. And I think there is this expectation that they need to learn and adopt some of these new workflows. And what I think is really fundamental right now is that pharmacy technicians take this opportunity to own that and be very proactive in the skills that they can implement in these settings, and learning how to go into the pharmacy systems, identify opportunities, present that report to the pharmacist and pharmacy owner and say, hey, these are the patients that are on asthma medications. Like, we can do education. I mean, we're already doing health education, motivational interviewing on, are they taking the meds appropriately? What are some lifestyle changes that are preventing them from being adherent to the medications? What coaching can we really do? That these technicians can really be proactive about identifying those opportunities, bringing them to their business owner and saying, hey, if you give me some time to work on this project, and we can clearly demonstrate that these clinical opportunities are bringing in revenue from clinical billing, I would really like to participate on that additional revenue that's coming in. I was at a pharmacy where I knew that, I could get paid more working at a CVS, but I loved my independent pharmacy family. But that was 10 years ago. Nowadays, you need to have a much better living wage and a career style wage. And, I am also, acutely attuned to the fact that pharmacies don't have more money. So this is really a way to be entrepreneurial within your existing environment.
Exactly.
To help your employer bring in more money and then lay claim to some of that success.
Yeah. Absolutely. Absolutely. I love what you're saying. And the reason is this is encouragement to the pharmacy owners and operators right now, who, when they hear you first say pharmacy technicians that are good pharmacy technicians, they've been there, they put in the work, they're helping to build the business, they need a pay raise. There's always the shriek in the room, because you're like, but that means that our profit margins and our it's going to all go down. But you're saying, you could leverage the technician, empower the technician, send them to conferences like the one I'm going to next weekend, SureCost, and SureCost, all about analyzing to the granular level, super duper granular level, where you have an opportunity to make money, canvassing physicians, reaching out to your patients with ancillary therapies and services and DME, and just dig into the business and show that these individuals who are taking initiative, putting in more hours, maybe you need to switch them to a salary, stop paying them hourly, and let them know we're going to put a bonus structure onto this engine that if you raise revenue in any way and you could build categories that you could track and KPIs and the whole thing, this isn't just Fugazi. If you started tracking each of those departments, each of those verticals at the end of a quarter or the end of a year, you could write out a bonus check because they were directly involved in impacting the growth with your physicians, the growth with your community, community events, diabetic education seminars. I could go on and on. We could sit and podcast for 6 hours of how you could have technicians literally bringing in more money to your pharmacy and in turn providing a lot more healthcare services to communities, especially those communities that don't have a pharmacy for 5, 10, 20 miles away.
Or a healthcare provider, in the same radius. And because there continues and persists to be a shortage of physicians across the U.S., like I know here in California, when we have our Pharmacy Advocacy Day in Sacramento, talking to legislators, their constituents are concerned about accessing healthcare. I mean, that's a different conversation from affordability. We just don't know where to go when we're feeling sick. We don't know how we're going to access, our endocrinologist for our annual appointment. And so there is this appetite to leverage, doctorates of pharmacy, 4 years undergrad, 4 years of graduate school. A lot of them have done residencies, and there is always post-education CE training that they continue on, that they should be leveraged more and that they should be paid for the work that they're doing.
Absolutely. Amantha, I so enjoy talking to you. You always bring extra ideas to me, and appreciate you sharing this with listeners. If you're listening, you're curious, you want to work with Amantha, she's active on LinkedIn, so look her up there. Also, go to rx-post.com. Once again, that's rx-post.com. I'm going to put that in the show notes. So if you're somewhere, you're driving, you can't pick up a pen or do something, don't worry about it. We'll have it in the show notes. Promise me you'll be back on TWIRx sometime sooner than later.
Yeah, and I definitely hope to catch you at APCI in Los Angeles next year, my hometown. It's 3 blocks away from where I live, and we can plan some special stuff for the pharmacy technicians together. I know that myself and Kristen Stair, another pharmacy technician who's very active and in the advocacy work, are hatching some special plans.
That's awesome. Yeah. Thank you for what you do, Amantha, and for hanging out with me and always being a source of good information to us. I appreciate you.
Thank you. You too, Todd. Keep up the great work.
This episode is sponsored by Independent Pharmacy Cooperative, widely known as IPC. Established in 1983, IPC is the nation's largest group purchasing organization owned by independent pharmacy. With a mission of maximizing the success of community pharmacists, IPC works to provide members with access to effective programs and services designed to enhance profitability for independent pharmacy. Read more about our mission by checking out our website at ipcrx.com. That's ipcrx.com.
Hey, welcome back to This Week in Pharmacy. I'm your host, Todd Urey. It's been great. This has been an exciting show. I'm excited about what's happening in pharmacogenomics. Been one of the topics and one of the subjects that I've just been fascinated with since 2016. 2019, we launched the first podcast dedicated to our pharmacists and physicians about PGX. And as you know, Dr. Melissa Smith has taken over the show and revolutionized it, taken it to a whole nother level. And it's been a hot week in PGX. Melissa, how are you?
I'm good. How are you this morning, Todd?
Doing great. So I want to just jump right in. You brought something to our attention. You brought on Karen Merritt, who was a fabulous guest on your show, going through the preventable toxicity, the pharmacogenomics case for testing in oncology. That interview listeners, if you have not heard this, is just tremendous. It's on all of your platforms, Spotify, Apple, anywhere that you're looking for podcasts. Just look up Pharmacy Podcast Network and you'll find it. What a great subject to just flag that. That's a prime example of how testing can save lives. And Merritt's story with her mother was just super impactful.
Yeah, when we first connected, that was the first thing we talked about, and she is very passionate about that. And that is her driving force to do what she does for advocating for this type of testing and for the FDA to update these labels for these medications like Xeloda and 5-fluorouracil. Currently, that's what is kind of the next initiative along with that, is to get not only Xeloda, capecitabine, that's just been updated, that testing's required prior to taking, and now getting 5-fluorouracil to follow suit. And it was just amazing to me that it took so many people being harmed by these therapies for it to come to fruition like this. Yes, this right here. So as far as the toxicities go, they're fast. And what she explained in her mother's experience, it was literally weeks, and then she was taken out through this medication. And had they had this testing prior, this may not have been the case for her mom. So this is why it's so important to bring awareness around this, making sure providers are knowledgeable of the testing laboratories that can offer this for them. Or even if you have questions in general and just need support, I'm a great resource for that. So you can reach out to me. I can get you connected with the right types of labs that are reputable, that are testing for DPYD, and making sure that you're well taken care of as far as being knowledgeable and feeling supported in that space.
Melissa, when I started researching, and my research is more about building show notes or blogs that will accentuate what topics that our pharmacists are talking about. Yes. And I would always go to this table of pharmacogenomic biomarkers and drug labeling, and it's been updated as of September of 2024. Mm-hmm. And I would expect them to do some new updates with some of the news that's come out. But when I first started the show in 2019, there were less than 200 medications that were listed on this. And now there's like twice as many. Mm-hmm. So once again, this drives the need for a pharmacist to be accessible, be available, and be knowledgeable about when to test, helping the physician understand the results, consulting with them, then of course counseling the patient. Can you give us some other examples of some other medications out there that have kind of thrown a reason to pause based on some of the data and studies?
Absolutely. This is a number one that I always go to with regards to Plavix, clopidogrel. That's a type of medication that if we do not have testing prior to it, and it's usually a first-line treatment when we're trying to prevent further strokes and heart attacks in patients, right? Antiplatelet medication. It requires activation through CYP2C19, and the pharmacogenomic testing is important to understand whether or not it's being activated. And then essentially we're getting potential treatment failures for these patients, the more and more compromised their CYP2C19 activity is coming back genetically. That doesn't even take into consideration the combinations of therapies that patients take with this commonly prescribed medication. Because like I said, it's a cost-effective medication, first-line treatment, generally prescribed post-stroke and heart attack for patients. And without having this knowledge base, patients, unbeknownst to their knowledge, without being tested, could be at risk for just being on a medication that's just worthless to them. So that's a big one right there. And many of the mental health medications have high levels of testing as well, because it can prevent side effects and toxicities, things like Lexapro, Celexa, Zoloft, very common antidepressants that patients take. And in the antipsychotic space too, as well, we have quite a bit of information there too. A lot of that guidance is around dosing recommendations and also potential toxicities from the therapies as well. I mean, And pain management. Pain management is another area. So many people are unaware of the fact that they could be taking something like Vicodin, something that is hydrocodone based for its opioid. And the activation of that drug is necessary to give you proper pain control. Tramadol and codeine also included within that literature. And many patients that I've counseled and I speak with regularly, their prior experiences typically, when I find that their CYP2D6 is intermediate or poor, it needs to activate those drugs in order for them to give you proper pain control, that their experience was, I had a ton of side effects, nausea, vomiting, dizziness, but no pain control. And many times providers, let's say that it's more subtle in the side effects. They may even increase the dose for those for patients, encourage them to maybe take one more tablet because it's 1 to 2 every 4 to 6 hours on some of those indications. And it's really just putting them more at risk for increased side effects and just less effective treatment. So the idea is really just to make it available to all and really promote the idea of testing foundationally, even at a primary care level, because it extends in so many areas of a patient's care, especially when it comes to their medications. And what I also want to say is that many providers are wanting the evidence, and the FDA table for these pharmacogenomic findings is a perfect place to send them because it's all consolidated as far as the level of evidence and what's being recommended, the phenotype, whether intermediate or poor metabolism is there. But the thing that still irks me a little bit with the FDA is that it's not testing recommended for everything. So it's the way that they label things is that it's either testing recommended, testing considered, or actionable evidence. And then for me, it just makes more sense for it to be available to all. I mean, it really does help with lessening the risk factor for adverse side effects or adverse drug reactions here. So for me, it still begs the question why it's still something that kind of is blocking a barrier here for it being able to be more accessible to our patients, right?
Yes. And I'd like to have an opportunity to dig down into the lobbying side of this because I know how that impacts healthcare.
Karen really opened my eyes to that as far as her work and advocacy there and what they actually have to do to get things. It's a lot of just calling and emailing and getting patient cases presented before the FDA for them to really make movement, right? And it's sad that it takes like adverse drug reactions and even potential deaths for patients for this to occur. This is a prime example with Xeloda.
I want to shift a gear for listeners because we are in an age where the dispensing fee is no longer going to sustain our pharmacists, our pharmacies, our privately owned pharmacies, our specialty. It's going to be more about the services and the knowledge that the pharmacist has that digs down into the specialty that they're championing. Shout out to Jenna Quinn and Perfecting Peds and her setting the world on fire of pediatric care and digging down into very complex situations where the pediatrician is stumped and they're like, we're not sure what to do. Well, kick it over to the medication specialist and move forward. But in building your business and building Florida PGX Consulting, what do you say to other pharmacists like you who've been drawn to the science and the testing of pharmacogenomics? How do you build your business? I mean, that's like the $1 million question, but you've been doing it long enough to kind of give us some insight to that.
Well, it's relationships, it's relationship building and trust. So let's say you're a pharmacist who's in a retail setting and like I was, and you're interested in trying to basically break into this space. A lot of it is entrepreneurial spirit, right? You have to start digging into what your state laws and regulations are with building out an LLC for yourself or incorporating yourself. Yes, all those things on the back end. But the most important thing is building the relationship with the practitioners around you. So that way that's a resource for you, a referral when it comes to needing testing for these patients, more complex patients. So in the independent pharmacies, this is a perfect space to introduce this because not only are you in better communication with a lot of the medical groups around you who are sending prescriptions directly to you, you have more of an opportunity to have that personalized conversation with practitioners and being able to open the door to helping to manage this type of medication information and testing for them. So that's where I see it being hugely impactful for independent pharmacists, because one, you're already brick and mortar. This is a place that people come to, you can easily test these things. It's an oral swab. It's very simplified instead of having to do blood draws and things of that nature. And you can incorporate that into the verification process, because let's think about it. I mean, we have drug-to-drug interaction review of information when we're at the pharmacy retail level, whether it be independent or large chains. But what we don't have is, a window into the genetics, the compounded risk factors that are not always considered or talked about. The concept is always there for us as pharmacists. Pharmacokinetics and pharmacodynamics is built into our DNA, so to speak. We get the concept of incorporating it. It's just a little bit of practice of identifying, understanding, and then combining the knowledge into the compounded risk between the drug-to-gene interaction and the drug-to-drug interactions. And that's the point of verification. I mean, truly, that's the last point of all oversight of the medications reaching to the patient generally. And not only does a practitioner need to be aware of this at prescribing, but it's the pharmacist at that end stage that needs to also be incorporating this into their verification process too. So for me, that's where I see it going in the future, truly, for pharmacists to kind of leverage that. But there's relationships to be had with the laboratory spaces as well, with consulting with them, because they need pharmacists like ourselves to be able to communicate this information to the providers. And many times that's where a barrier for ordering comes, is there, I don't want to say lack of knowledge base, but it has to do with being able to understand the report they're receiving, utilize it to their advantage, and being able to implement it when actually prescribing for the patients too. But they need to have advocacy as well. And that's where the pharmacists need to come in and play that role.
So being a non-pharmacist, but I have hung out in technology to support pharmacies for so long, I'm very frustrated. The NDC list is there. You come up with a medication, one of those medications that we just showed on the screen that was, being flagged by FDA, that I guess that's probably the bucket of black box warnings or whatever. But regardless, an NDC could easily be identified in a pharmacy management software system like PrimeRx or Pioneer or whatever. And every time that medication is subscribed and is brought up for processing, the pharmacist during final review would get a message to say, here's the statistics. Now we have AI, for God's sakes. Here's the statistics on this medication. Here are the latest articles on this, medication. Here's what to look out for. At that point, in my opinion, because of the stewards of safety that you are, the pharmacists are, reaching out to that physician either electronically or picking up the phone or doing something, I would hope would be electronic, just from the pharmacy management system to the EHR, and flagging it back to the physician and saying, hey, listen, I highly recommend that we run a pharmacogenomics test. And by the way, I'm ready to do it here at the pharmacy, or I'm ready to do it here at my consultant space, or wherever you guys are. And can we move forward? And then, but what I'm talking about, of course, this would be fluid. It would work nicely, but
it's like when you send somebody over to have a vaccination done.
Yeah.
Right. And the other point of that is making it accessible and cost effective for the patient. That's where we have a true barrier in care as well, because a lot of insurance companies, commercial insurance companies, are not readily covering the cost of this test yet. FSA and HSA will cover the cost of it. But when the insurance process comes into play, it makes it extremely difficult for it just to be covered like a vaccine is, and it be free for them. This is what we really, truly want to get patient care at when it comes to this level of testing, making it that much more accessible. And that's where I feel is kind of like a break in the chain, right? For patients being more apt and wanting to participate. I don't think it's a patient level issue at all. They all want this information, but it is a barrier when it comes to the cost end of it.
So I just talked with Michael Banville yesterday, who's probably going to be on TWIRx in the future.
Nice.
He's working with a company called All's Path, and they're doing testing that is tied right into DNA and the effects of medications on people that are on certain treatments. And I've talked to him about our deep resources that we have throughout the network, and starting with you, leading pharmacogenomics. I'm going to put you guys together for a future conversation. But the reason why I'm bringing that up is, once again, I just feel that from the FDA's point of view, and however that trickles down, including payment through CMS and payment through private insurance, that we have to come to a point where it's not waiting on the physician to run the test. It's going back to a certified, as well as I do, there's board certifications. If you had a certification of some sort in pharmacogenomics, and
which is not there yet, but I know that people are advocating and pushing for the board certification for this.
Yeah. But if that were the case, to unclog the bottleneck, which is going to become the physician, because they're so busy, and why in the world we have a setup that it's the pharmacist that makes the determination, that says, hey, this CPT code and this ICD-10 code and this over here gives me the right to run a test for my patient because this medication has been flagged and it could be harmful. So therefore, let's run a $400 PGX test, or however much that they are now. When I started and do it in 2015, 16, it was like a $2,200 test. And now I know that it's certainly not.
It's much more reasonable for a cost perspective. And when you think about the actual cost of adverse drug reactions, which can be into the hundreds of thousands and even more advanced cases where they're staying hospitalized for longer periods of time because of these things, towards the 500,000s, even the millions. I mean, a $400 test is nominal in the sheer comparison of cost. So it's something that's utilized over and over again. You're not having to be retested like a metabolic panel. This is something that you test once, and then until there's more evidence or additional genes to be brought into the picture, which takes a long time to do, that's when maybe additional testing would be necessary. But when you have more comprehensive gene panels, like having anywhere from like 39 genes being tested, as opposed to limiting to maybe 20 genes, that also opens the doors for more comprehensive review and extension into more, rare type medication testing already done up front, not delaying care in any kind of chemotherapies, for example, like with Xeloda. That's a great example, because the way it's phrased is within the FDA update is that testing, we are recommending testing, but if it means delaying care, you can still begin therapy prior. And who would want to do that, knowing the intensity of onset of these toxicities potentially for patients with these deficiencies already? So I feel like that's a liability even for the FDA to put that language in with even that update. You know what I mean? I think it should be testing required prior to starting. And if we already have patients within the system, within the healthcare system, that are just being tested automatically for these things, it's not going to delay care at all. They're just going to have it accessible already and just know right away, and then getting alternative therapies being recommended, as opposed to waiting on this information, which can take upward to 7 to 14 days with some laboratories, right? So that really can delay care.
Melissa, this is awesome. Really appreciate your insights and intelligence for the Pharmacy Podcast Network, and the work that you're doing for your patients, but also the education that you're bringing and the partnerships that you're bringing to our physicians, and the support that you're extending, and excited to see the business growing. It's Florida PGX Consulting.
Yes.
Take a look. Link up with Melissa on LinkedIn. I cannot wait to have you back on TWIRx.
Yes. Thank you so much for having me again. I always love doing these.
All right. Thanks for listening to TWIRx today. We'll talk to you soon. Have a great week.
As frontline healthcare providers, pharmacists like you understand the importance of personalized care, especially in acute pain management. Ural Pharma is dedicated to providing high-quality, generic products tailored to meet your patient's needs. The company aims to serve a diverse range of patient populations, including athletes recovering from intense training, weekend warriors managing minor injuries, and those seeking a practical and mess-free option for acute pain management. Keep Ural in your toolbox of pain management options and join the ranks of pharmacists leading the way in personalized care. To learn more about Ural Pharma and its products, including full prescribing information, boxed warnings, and important safety information, visit uralpharma.com. That's YARAL pharma.com and connect with them on LinkedIn.
Hey, welcome back to This Week in Pharmacy. It is a good day, November 7th, 2025. Can you believe it is almost the end of 2025? I remember when it started and I'm like, I'm gonna be 20 pounds lighter, and I'm only at the 10 spot. I'm gonna be more fit, be more healthy. So far that's going good, but what's your end of year look like, and what are you planning for? You have to start planning now for 2026. And part of planning is how we work with government officials, how you educate your state representatives, how you're embracing your state pharmacy organizations and planning with them that if you do a tour with a state representative or a senator to teach them about how you're impacting your community and community health, get your state pharmacy association involved and make it a thing. Like get press involved and get the educations out there. More has happened in PBM reform and righting the ship than ever before in my 20 plus years in pharmacy. And if I'm looking at things from just a pharmacy perspective, what better governor to have than Governor Huckabee of Arkansas, because she is a fighter and she's fighting for independent community pharmacies, and she's fighting for better access, and she's fighting for fairness for her constituents. And I think it's going to bleed over. I know it's going to bleed over into other states. But today on TWIRx, we are welcoming a good friend of ours here at the Pharmacy Podcast Network, Greg Reybold of APCI. Greg, welcome to TWIRx.
Todd, thank you so much for having me. Always a pleasure. I'm particularly excited to be here today with your other guest.
Absolutely. And we're talking about pharmacy associations. This is the guy of the Arkansas Pharmacists Association. And I'm kind of jealous because he probably knows Governor Huckabee and probably has met her. So we want to welcome John Vinson. John.
Yeah, it's great to be here, Todd. Good to see you. Good to see you, Greg.
Hey, John.
Hey.
So Governor Huckabee, have you had a chance to meet her?
Yes, actually I have. Governor Sarah Huckabee Sanders she's actually the youngest governor in the country. She's in her early 40s, and she is finishing up a first term and working on, I think filing day started this week in Arkansas, and she filed for a second run at governor here in the great state of Arkansas. And we have had a lot of great interactions with not only her, but some of her key leadership and team and staff are very accessible, interested in our issues, and it's been good to work with her.
Yeah, Governor Huckabee Sanders was also at the NCPA 2025. I didn't get to meet her. Too much was going on, but it was great to see that she took time to talk with pharmacy owners and in the NCPA. I thought that was wonderful. Hey, This Week in Pharmacy, the reason why I'm so excited to have you here, John and Greg, is to talk about things that are pretty hot on the press, and that is Sanders, Governor Huckabee Sanders announced Arkansas's application for rural health funding. And John, you brought it to my attention how many times pharmacy and pharmacist were mentioned in this press release from the governor's office. And Can you take us through this and what this means for Arkansas and what this means for pharmacy and pharmacists in Arkansas?
Yeah, sure. We're still digesting it ourselves because it's hot off the press this week, but there's about 125-page application that went to CMS, and most states, if not all 50, are in the process of doing this. This is the time of year where the administration will be reviewing proposals to provide $50 billion in funding across the country. So Arkansas's application, it was announced this week, they're asking for $1 billion. And we did submit ideas from the Arkansas Pharmacists Association, from Arkansas CPESN, which is a clinical integrated network, as did other organizations. I know Walmart submitted ideas and some of our national partners to our governor. And we were able to meet with Secretary Jim Hudson, who was the chairman of the committee that reviewed these ideas, and their team that put the proposal together. So not necessarily in the press release, but in the full 125-page actual application, which is included in the press release, the link, pharmacists are mentioned a lot and a big part of what rural transformation should be. Our pharmacy owners, our pharmacists that work in Arkansas have business practices in all 75 counties. And of course, they work in hospitals, nursing homes, and community practice, primarily seeing patients. And we do have community pharmacy practices in all 75 counties. In our state, about half of those are independent pharmacy owned still. And it's a good mix with really strong network of pharmacies. And then within that clinical integrated network within our state, 180 of those are part of that clinical integrated network. So we're well positioned on practice transformation, on delivery of care in new ways, whether that's telehealth, whether that's being paid for our time, for our expertise, and other innovation ideas that are going to come out of this. Pharmacists are going to play a big role, and we appreciate the partnership with the administration.
That's incredible. Greg, that's some good news. How does this tie back to, your concerns where you oversee all 50 states? You have members in all 50 states, but this could become a domino effect where we take other successes and other wins in other states and try to spread this throughout the entire country, because we know that pharmacy deserts are ravaging healthcare access to so many people throughout the country.
Yeah, absolutely. And look, I think, just to reinforce your point, right, in terms of serving as a model, I'm going to give John and Arkansas a compliment here, because what we see really over and over again is Arkansas serving as a model and sort of shaping pharmacy in a variety of different ways for years and years and years, right? John, I think 2018 there was, big legislation that helped shape things, sort of shape national policy and the direction other states took. And this, to me is fascinating, because obviously you're working really hard on this rural health angle and leading on this, but that's not the only thing you've done this year. That's not the only thing you've done this week, is it? Right? Like you're in the thick of it on the legal front as well, correct?
Right. We had an amicus brief released today, or not today, but this week, and did a media interview today about that with the not the Supreme Court case, but the Eighth Circuit Court of Appeals with relation to a piece of legislation we're probably going to get into in a few minutes. But that was released today. The Community Oncology Alliance, which represents oncology practices and pharmacies in Arkansas and across the country, also released an amicus brief, or a friend of the court brief, this week. So it's crazy. There's a lot going on.
Yeah. By the way, right, like we're talking about a pharmacy law being in the Eighth Circuit. Arkansas is the state that effectively, took a pharmacy issue, the ERISA issue, all the way up to the U.S. Supreme Court, got cert granted, and then won before the U.S. Supreme Court. So you guys, the state of Arkansas is no stranger to fighting to enforce state pharmacy laws. Led on that front too.
And I always like when we're talking about some of the cool things Arkansas is doing. Todd, clearly it wouldn't be possible without our national partners, without APCI, NCPA, APHA, as well as NASPA and lots of other states. There have been many leaders. It's not just an Arkansas thing, but we learn a lot from each other. And North Dakota, West Virginia, Iowa, Alabama, Montana, Oklahoma, Georgia. I'm going to leave somebody out. Tennessee, the point, Louisiana. I mean, there's a lot
Kentucky.
making Kentucky big time. Ben Mudd over in Kentucky and their group. There's been a lot of success and movement, but Arkansas has certainly, over the last 20 years and certainly in the last 10, been very aggressive at protecting patients and fighting for our profession.
Love it. Yeah, shout out to the pharmacy associations out there. If you want to get on This Week in Pharmacy and give us an update, we know what happens. These other states are listening. They're watching the news. If we can spread some good news, if we can spread some progress in PBM reform, you have our microphone at your disposal, just to let you know. Hey, John, you started letting the cat out of the bag why we actually brought you here. So let's jump in before it jumps out itself. And that is HB 1150, Arkansas State Legislator, to prohibit a pharmacy benefits manager from obtaining certain pharmacy permits. I absolutely love this because in my uneducated opinion of not having an MBA or not even having a PharmD, I don't think any insurance organization should be allowed to own or operate pharmacies. I think that's a complete conflict of interest. This is getting us much closer to such a setting.
I agree. Thanks, Todd. It is a very simple bill in terms of it is a conflict of interest to be both the fox and guarding the hen house. And this bill simply eliminates that conflict of interest and says you can be a licensed PBM or you can be a licensed pharmacy, but you cannot be both. And there are, pick one or the other in our state. And there are too many instances, both in examples from patients, from data collected within Arkansas, as well as Wall Street Journal, New York Times, Federal Trade Commission on 2 different occasions in the last year, U.S. House oversight led by Chairman Comer of Kentucky, where we are seeing patients forced to pharmacies with 1-star or 2-star reviews that get bad service, poor healthcare outcomes, and they're paying billions of dollars more. So they're capturing up to the latest Federal Trade Commission report showed that 3 pharmacies are filling 70% of all specialty and brand drugs in the United States, owned by 3 PBMs. And in doing so, and the markups are billions and billions of dollars.
Massive. So, Todd, we were looking at some data in Federal Employee Health Benefit Plan last year, and this was a plan where the PBM required their mail order specialty pharmacy to fill the prescriptions. Patients couldn't go anywhere else. The beneficiaries in this federal plan. And we found markups. This will be the highest markup we found, but we found markups for MS drugs that were as high as 47,000% over the national average drug acquisition cost. 47,000% markup to treat patients with a really, really serious condition. And oh, by the way, their choice was restricted.
That's horrible.
And it's normal in other industries to have these conflicts of interest banned. For example, if I'm Anheuser-Busch and I make beer, I cannot also be the distributor and the retail sales.
Yep.
They're required to be separate. And it's because when you are all one, you can abuse the system to benefit yourself. And there was a report just this week nationally in Stat News that one of the 3 big PBMs also owns physician health practices. And they're finding that they overpay the practices they own by 17% on average. And in areas where they have a market concentration of greater than 25%, they're overpaying themselves compared to other physician practices by 61%.
Yeah, and
So pharmacy is the tip of the iceberg.
it is the tip of the iceberg, and a point that I'm glad you brought that up, John, and something that I think is important not to get lost in that is this isn't like aberrational or statistically insignificant, right? This isn't an insurer that owns a couple of physician practices. They're the largest employer of physicians in the country, or one of the largest employer. I think they're the largest employer of physicians in the country at this point through, aggressive acquisition. So we're not talking about, hey, they're paying themselves more and it's a blip on the radar, right? These insurers, these PBMs, they're so big that their practices, the minute they start them, become entrenched on a massive scale, right? And it might feel normal, it might feel normalized, but it's not. They're just doing it on as big of a scale as it could be done.
It's nuts.
Nuts. But John, really glad you brought that up, because frankly, that's a big story that came out this week, and it should be bigger. Todd, I'd like to add, look, obviously the work that Arkansas did this year in passing this, getting this signed into law, is nation leading, and it's going to shape again a lot of policy. A lot of states are looking at this. I think it also helps build momentum at the federal level. I expect to see patients before monopolies reintroduced at the federal level as well. That was introduced by Senator Hawley and Warren and Congress and Auchincloss and Harshbarger. And so I would anticipate seeing that again. And the success that Arkansas had in that, I think, will help build momentum for that. But as big of a story as Arkansas and the pharmacists there, helping to support the passage of that law, to me, one of the maybe a bigger story, or as big, is that in the face of like massive pushback and adversity, Governor Sarah Huckabee Sanders has just become just an amazing champion for standing up to PBMs and not being intimidated, but also just a champion for pharmacy. And she's leaned into that, and boy, is it amazing to see.
It really is, and it's refreshing to see how a governor standing up for her residents and her constituents and people. She knows the dollars that are flowing through the state systems and Medicaid, for example, and how dollars are being given to big organizations to raise their stock price instead of for covering meds of people who are not buying groceries because they don't have medication. And it's just silly. It didn't make any sense to me when I first learned about PBMs and understanding what we've done. And when we started the PBM reform podcast that you now host, Greg, it's an education for us all, but it's also tracking. We've been tracking this since 2019, and it's people like Sarah Huckabee Sanders that's making huge abilities for us to finally make way and to get attention. And then you sprinkle Mark Cuban into that, and you sprinkle Representative Jake Auchincloss that keeps showing up everywhere. He's on TikTok, he's on Instagram, he's on the news.
Absolutely.
It's like we're chipping away, and I'm finally seeing huge cracks in these behemoth three big players that I think we're going to finally get to the. You guys remember in the 1980s, the divestiture of AT&T and how they broke it apart? Like that's what has to happen. We have to, for the consumer's sake. And by the way, they're not even as a 16th as evil as the as the benefit managers are.
Todd, I'm glad you brought that up, because that case was part of what inspired the law. And then the Patients Before Monopolies Act at the federal level gave us the idea. And when you go back to the Federal Trade Commission breaking apart the bells back in the late 70s, early 80s, that was a 10-year process. It took 10 years. So it was the right thing to do, but it took a decade. So at the heart and core of Act 624 HB 1150 at the state level is our governor, our attorney general, and our elected state legislators in the Senate and the House felt like there are patient lives at stake, and they will die if we wait 10 years.
John,
we can take action now and protect our citizens.
John's paid me to ask this question, John, but how it took them a decade. how many days did it total days? How many days did it take you to get this sucker into, your support to
It
get this
was
bill across the finish?
yeah. Well, it was definitely a year of conversations. It
Yeah.
was filed in early January and then had to have a fiscal note and be evaluated and all the things that usually happen. But when it actually got introduced in committee and ran in committee and then to the floor on both chambers, started in the House, it took a week. It
Took
was
a week.
fast
Amazing.
because we had spent months and months and months educating, working with leadership, and getting to a position where leadership in both the House and Senate, governor's office, and attorney general were all behind it and supportive.
Yeah. And I think for context, I say this often, right? So often independent pharmacy, community pharmacy can be the canary in the coal mine. They're seeing the steering, they're seeing the exploitation, they're seeing the markups. But, this is a bill that targets, this is a law now that targets vertical integration, right? This isn't a pharmacy bill, right? There's nothing directly impacting non-vertically integrated pharmacies, right? This is a pro-competition bill. This is an anti-monopoly bill, and this is something that really, at its core, targets vertical integration. Todd, if you'll indulge me on this, if you took that bill away this year, right? If that bill didn't pass, if that bill wasn't introduced, and you look at the other bills that were advocated for in Arkansas, Arkansas still would have had one of the strongest legislative years in the country for community pharmacy. John, would you mind talking just a little bit about some of the other work that you did this session?
Yeah, sure. So several things leading up to the session. There was a rule that supports an existing law that requires PBMs to show their homework on their payment methodology to cover not only the drug, but cost to dispense. That's Rule 128. And then there's a prompt payment bill that requires and there was legislation to clarify and strengthen any willing provider laws in Arkansas and access, and to ensure that specialty drugs and certain drugs that are covered by our PBM laws are not forced arbitrarily and block an adequate network for patients. And the private right of action bill that Greg mentioned a minute ago that provides a pathway in the courts litigation more clearly for pharmacies that are negatively impacted from lawbreakers, if
And that's
you will.
a big deal.
Yeah.
I mean, that obviously it's like just a smorgasbord of policy, good policy that you worked on and pushed through, which is amazing. But
yeah,
I love the private right of action.
Yeah, network clarity and transparency like North Dakota has, where they have to disclose to the PSAOs and the pharmacy on contracts which bin and groups are included. What type of plans are they? Are they self-funded? Are they federal? Are they Medicare D? Make that more clear on the front end. Prohibitions against opt-out contracts without 60 days notice and certified mail. I mean, just a lot of little things that will make practice from the business side easier. Did not have as many this particular session scope related issues, but we've had some advancements in that in recent years as well, consistent with the rest of the nation, and also payment for services. So you got two baskets here of business and then professional that we work on. And this particular session was more business focused.
But yet here you are post session, you're working on rural health and working with the state and the federal government on that too. So
right, for clinical practice and payment for those services. Yes.
Excellent work, John. Bravo to you and your team at the Arkansas Pharmacists Association, and also how you're tying into the national organizations. And there's a lot of nonpartisan support of what's happening. The only organization that seems to be upset about this is CVS Health, and I read their January or June 10th rebuttal about what Governor Sarah Huckabee Sanders had wrong, and I read through it, and it had nothing to do with what's best for patients. It had to do with what's best for their business and the ability to not associate or do something with their pharmacies bring them out from under the umbrella. There's nothing. It's like reverse merge. I mean, they're gobbling up insurance companies and practices and pharmacies, and so just turn it off for the state of Arkansas and try and stop trying to make it like it's detrimental to nothing more than your business. It's not an impact to healthcare. It's giving people a choice, and it's evening the playing field. And obviously their rebuttal was laughable.
Mm-hmm. And what Todd's talking about is the governor's op-ed to the New York Times, which is pretty cool to see her.
It was amazing.
Submit it. Yeah, it was awesome. It was very well written. It told a story about a constituent, a patient who was unable to fill or access her breathing treatments, which resulted in delays in care, harm, emergency room visit, and hospitalization because of the harm that this vertical integration does. And the bill is really, it is not, or the law now, it was a bill, it isn't law now. Yes, it will improve the market and improve the ability, because an independent or a small pharmacy or Walmart or Walgreens is never going to get a fair contract if the person they're trying to sign a contract with also owns pharmacies. Never going to happen. But more importantly than what it does for the market is about protecting public and patient health and safety. And that for many, many years, Greg's the attorney here, that is a state's rights to decide who is licensed and how do we best protect health and safety. That is not a federal government responsibility, or it has not been historically. That has been left to the states to decide that. So that's why part of the idea of why we could tackle this in the state. And just from a nuance thing, it is not enforced at the insurance department. It is about licensure of the pharmacy through the State Board of Pharmacy.
And to
you
John's
qualify
point,
or you don't.
Yeah, and to John's point, licensing is squarely an area within states' rights, right? Historically,
yes,
there's massive precedent for that.
And there is no carve out for Walmart. I don't care what you read in the national news. That is a lie. That does not exist. There is no carve out. Walmart does not own a PBM. They hire one like the rest of the employers do that are not affiliated with PBMs. The case is not dead. The case is simply in a phase right now where they're deciding, is it the enforcement delayed? And we see and listen and hear the merits of the case. That's kind of where it is right now at the 8th Circuit, and trying to decide, does it go into effect January 1st of 2026, or is the enforcement delayed until the courts can hear the merits of the case?
Yep.
Greg, why don't you add from the attorney side?
No, I think that's right. There's nothing that's happened in this case at this point that would give me pause or make me, feel uncomfortable, right? I think it's gone the way one would largely expect it to go.
Mm-hmm.
Don't want to get too much into the legalities, right? But they're leaning, one of their core arguments is sort of this obscure dormant commerce clause argument, essentially trying to argue that, hey, this favors in-state versus out-of-state. This is a law that targets vertical integration and the anti-competitive harms that come from vertical integration. So I think
regardless of where you're located.
That's right, regardless of location. And
it was purposefully drafted not to do that.
Yeah,
I mean, it was yeah.
Yeah, again, and I think that one of the things we see is Arkansas has not blinked, right? They have leaned into defending this just enthusiastically, and that's a testament to them and their fortitude, because a lot of states do blink and they haven't. And I think it's a testament to the work of the association and John and the pharmacists in that state. This is a little bit less technical. I don't know if this is a legal analysis or not, but when you hear John list off everything they've done this session, for the folks who are watching, you can see this. For the folks who are listening, you can't. You have to take my word for it. John doesn't even look tired, does he, Todd? Can you vouch for that? He looks like
ready to go.
Unbelievable. All this, right? Prolific year. Doesn't even look like he's lost any sleep. I don't know how he does it.
I do think you have to go. I know I'm shouting out to the association again, but you do have to be organized. We went up against the most money ever spent in the history of our state trying to kill a bill. I'm talking billboards, unlimited television commercials, digital media strategy, emails to patients, automated emails and phone calls, a call bank center where human beings are calling patients and calling legislators.
John, they were driving around.
A truck with a billboard, electronic billboard, driving around the Capitol, vote no on. I mean, this is Washington, D.C. type of money spent in Arkansas, little old Arkansas, 1% of the population to try to kill this legislation. And in the federal court hearing, they admitted on record that this bill impacts and disrupts billions and billions of dollars in revenue going to those 3 PBM-owned pharmacies on they didn't say specialty and brand, but that's where a lot of the revenue is coming from.
That's right. Yeah.
Incredible. Incredible work. Well, once again, congratulations on all the work that you've done, John, and congratulations to the Arkansas Pharmacists Association, and a shout out to Governor Sanders, Governor Huckabee, Sarah Huckabee Sanders, just for standing up once again for people and for hardworking people that just want, you know, they just want to be able to get their medications affordable and access to it. And I hope that this spills over to more state governors to really take a look at this and really to dial in, because it'll impact the state's budget as well of where the money's going, how it's being allocated, and how it's being used for especially rural health, where you don't have access. You have to drive 10, 20 miles to get to a pharmacy in some places because of the shutdown. They did it to themselves. They closed down all of Rite Aid. They started closing down Walgreens. They're closing down parts of CVS Health, and it was like they ate their young. They did it to themselves in the way that their model was.
And the law does impact both brick and mortar and mail order, to be clear. So there are 650 mail order licensed pharmacies in Arkansas. 100 of those roughly are PBM affiliated. So that means even if all of them chose to be a middleman and make more profit than delivering healthcare, if that's what they choose, there would still be 550 left. And it would strengthen and grow as more opportunity was there. And then at the brick and mortar level, there are about 36 of 740 brick and mortar pharmacies that would be affected. None of them in rural areas that are more than a mile or 2 away from an independent or another chain. So all the ads of 2.7 million Arkansans are going to lose access in rural Arkansas is not true.
Yeah. It's lose access to CVS Health. That's what they're losing access to. Unless they, like I said, just drop the PBM part of it in the state of Arkansas and move on with the pharmacy business, but they can't stand toe-to-toe to independent pharmacy. So that's probably the reason that they're, you know, upset about that portion of it, because once again, it's hard to compete with a organization, a small business that's part of the community, that's grown up in that community, that knows people, you know, in person and is vested in the health of their community. And that therein lies, you know, how this combination became more about, once again, about those profits that had nothing to do with healthcare.
And there are dozens of licensed PBMs that don't own pharmacies.
Exactly.
So there are, you know, if they were to lose their PBM license or give it up in Arkansas to be a pharmacy instead, they could certainly do that, and businesses could choose to select one of the other dozens of transparent, non-vertically integrated PBM. I mean, it's possible to do that. The market would improve and patient care would improve if that happened.
Absolutely. John, promise you're going to come back and spend some time with us, give us some updates later in the year.
Yeah, this has been fun. Thanks for having me, Todd. Appreciate it. It's good to see you, Greg.
Yep, always a pleasure.
Greg, thank you so much for all your work. Thanks for hosting the PBM Reform Podcast, which you can hear on the Pharmacy Podcast Network. And what's up next? You want to drop us any hints to who your next special guest is going to be?
Yes, sir. Well, we've got some big ones coming up, so I'll just leave it at that. And I'm hopeful that we're gonna be able to get one of them. We're waiting on some federal action, and I believe we're going to see some federal action soon, and that'll be one worth listening to for sure.
All right, gentlemen, thank you so much for being on This Week in Pharmacy. Listeners, We will be right back with more TWIRx. Hey everyone, it's Todd Uri with the Pharmacy Podcast Network. I could not be more excited to talk to you that we're going to be doing the SureCast with SureCost at the Insights User Conference on November 13th and 14th. I'm going to be part of this event. I cannot wait to meet with you, talk with you, leverage data together, learn how to use data better. And it's going to be an incredible opportunity to connect with other pharmacy owners and innovators, colleagues who are all working together for the same goal, helping pharmacies thrive. And what better way to capture those conversations than a live event? That's SureCast. And I can't wait to bring this to you, sit down with so many of you. This is going to be in Nashville. Don't forget, on November 13th through 14th. And there will be a link to go to the registration, and we'll see you there. Hey, special feature on This Week in Pharmacy. You know, if you listen to the show, if you listen to anything that I participate in, you know, audience, how excited I get when I get to meet people in pharmacy, pharmacists that are making a difference. And when I think of history, when I think of where pharmacy started, and we just got done through Pharmacy Month. This month, it's about different disease state management. I think it's Diabetes Month. But when I get a chance to connect with people who are generational pharmacists and people who are passionate about our profession, and this individual is part of CO Bigelow, the oldest apothecary in the entire United States, I want to introduce Alec Gingsberg to TWIRx. Come on in to TWIRx. You don't have to TWIRx if you don't want to, but
thanks so much for having me, Todd. I'm really excited to be here.
Excited to have you. All right, that's a big thing to say in the country. The oldest apothecary. Tell me about your generational. You've been soaking in it since you can remember. You probably don't remember.
Yeah. Exactly. So, CO Bigelow, we say we're the oldest apothecary in the United States. And I'll clarify, it doesn't mean we were the first one ever founded, but we are, as far as we know, the oldest that is still continuously operating. So we were founded in 1838 in downtown New York City. We're located in the West Village for those locals on 6th Avenue and 8th Street. Founded in 1838, actually, we were called the Village Apothecary Shop by a doctor named Galen Hunter. And through the years, the pharmacy was passed down to kind of different employees. And in the late 1800s, a pharmacist named Clarence Otis Bigelow took it over. He built a new building for the pharmacy literally right next door. So same block and everything, but just a brand new building in 1902. Renamed the store after himself, CO Bigelow, and he was kind of like a master marketer. Yeah. So if you think back to what medicine was like, 100 years ago, even there wasn't the modern commercial medications. Like you couldn't go to a doctor and have him write you a prescription for Lipitor and go to the pharmacy. That's where the term apothecary comes from. You would go to the pharmacy or the apothecary, and they would have, everybody who worked there would have their individual recipes, like you can see on the screen there, and they would mix them up for you, and you'd go home and you'd kind of hope that you picked the right guy to make the thing that he thought was going to work for you. So what Clarence Bigelow was really brilliant at is, instead of like every other pharmacy apothecary kind of just giving it to you in like a plain jar, he said, we're going to wrap everything up like a gift. We're going to make it beautiful. And that's where his kind of marketing mind came for. And if you imagine somewhere like, New York City, you takes you 3 hours to get from uptown to downtown in like a horse and buggy. You wait in the pharmacy for 4 hours after showing like your itchy skin and hoping that the guy's going to mix something up for you. And then you get home, and of course, it's not going to work immediately. But like you could spend your whole day waiting to get this thing that you thought was going to cure you. So he realized if you wrapped it up like a gift and made it beautiful, like that placebo effect almost, I hate to use that term as a pharmacist because of course we were making things that were real, but you kind of tricked the patient into believing that this was going to work much better than anywhere around you. So that's kind of where CO Bigelow got its name and its reputation from. And of course, we're famous for treating, like, Thomas Edison lived around the corner and he ran here to get a salve when he burned his finger in, inventing the light bulb. Eleanor Roosevelt, Lou Reed, David Bowie, tons of, major names. But in the 1930s, during the Great Depression, the store kind of became run down. And my great grandfather came over from Poland to escape the war. His name was William Gingsberg. He studied by candlelight to go to Columbia University Pharmacy School. And he wound up buying the store in 1939, and just sort of kept it going, as he was a very ethical Eastern European pharmacist who wanted to make prescriptions and do good in the community. And he just kind of kept the name going until my grandfather came into the business, and then my father eventually in the 80s. And I joined full time in 2016. But of course, we all grown up working in the store. When I was 7 years old, I was wrapping gifts at Christmas time. I've been the delivery guy. I've worked as a cashier. I had been a staff pharmacist for a couple of years right when I graduated, and now I'm sort of running the store and the operations of the store, the pharmacy. And I don't know if we'll get into this today, but we do have a large cosmetic business based on all those formulas that I had just mentioned. We have, as you saw on the website, the archives, the history books, those formulas that doctors used to make. And our product line we've created is based on all those original formulas that are just as good today as they were 200 years ago. Just because we have all these modern products and modern medicine, it doesn't mean that rose salve is not as good as it was in, 1850.
Yeah. Well, I didn't know this was going to turn into a marketing and business development episode, but it's kind of a gem. And I want to say this. So there's been a massive, massive effort. It's been percolating for about 10 years, but more so in the last 2 years. And that is to get away from your primary source of revenue having to be captured by a PBM or captured by an insurance. That if you could do something else in pharmacy that is beneficial to the public, but doing it in a way that attracts the public to feeling like this is a better quality product because it's backed by a clinical pharmacist, and you start to dial into that. This website, everybody just listening, if you're driving in a car, jogging, us, we're going to have it in the show notes, but it's bigelowchemist.com. Even the name, Alec, gives me a sense of quality as a consumer. I'm not a clinician. I'm not a pharmacist. I'm not even a pharmacy technician, but I've been documenting our profession for 20 years and dialing into what works, what brings in the client, what brings in the customer, the patient, to start trusting. And the pharmacist is the number one trusted provider in healthcare, seeing their patients 9 times, if not 12 times more than primary care. It gives you so much access to people, and people are emotional. People could be taken advantage of. So if I'm dialing into a woman's skin and she has eczema or she has sensitive skin because the winter, I know during the winter months we use heat in our house that's electric. It dries our skin out. If I went to the pharmacy and I saw this gorgeous setting of products, against the end cap, and I got to walk in, and all of a sudden someone approaches me and they're like, "Hey, do you have any questions on, our skincare line?" Oh my gosh, like that's a boutique. It's taking pharmacy and it's bringing it back to what it was, but then it's wrapping it in professionalism.
And that's sort of one of the questions that I get more than anything is, what actually is an apothecary? Because I think, what I just described to you, going to a pharmacy 100 years ago and sort of like having a bespoke product made for you, that's what an apothecary was in the truest sense before modern medicine was created about, 60 years ago with the invention of penicillin. But I think today what I tell people is an apothecary means you're getting bespoke treatment. And that could mean that we're making a specific product for you, but it also could mean that the pharmacist comes out from behind the counter and really teaches you about, the medicinal properties of the certain products that you have. That's the difference between the chain pharmacies, the CVS's and a place like Bigelow or any neighborhood pharmacy across the country. I think that's what the spirit of an apothecary is. And again, I try not to like knock the chain pharmacies, but I think the nicest way that I can put it is if you go to a CVS, it's no secret that there's probably going to be one pharmacist who feels extremely overworked just checking their prescriptions. Bigelow's, we do about 500 prescriptions a day, and we do that with 3 full-time staff pharmacists, not including myself, my father, and Bruce Schreiber, who's the manager of our pharmacy and on the floor every day. So our philosophy is every single person who comes into the store with a question for a pharmacist should be able to have as much undivided attention time with that person as possible. And I think that's the spirit, that's the true spirit of the apothecary. Our pharmacists don't run out to answer a question and be like, I have to get back and answer the phone and check a script. If there's somebody there who needs to spend an hour talking about their gut health or their skin, our pharmacists have time to do that, as well as our technicians. It goes on to them as well, where most pharmacies have technicians who also serve as like the cashiers and the customer service people. We separate those roles completely. I have 5 full-time technicians who are strictly technicians. They are the experts in insurance. And just like with the pharmacist and the apothecary idea of bespoke treatment, those technicians are specifically like, if you have insurance questions, they can spend as much time as you need explaining things. I always say to them, as pharmacists, we know at this point, unfortunately, because of the nature of the business, we're never going to be able to solve every problem. We're not going to magically be able to make your copay disappear, your deductible lower. But if we can teach you something, explain to you why things are the way they are, then you at least feel it builds that trust that you were talking about and that personal connection, which is incredibly, incredibly important in a store that is supposed to anchor the neighborhood, which is what a pharmacy should be doing. And yeah, that's the philosophy of Bigelow. You touched on something before that I wanted to follow up on, which is unfortunate. I know most of the people who listen to this, I assume, are pharmacy owners or pharmacists who are trying to get to the business of pharmacy. It's no secret to any of us at this point that you cannot survive just filling prescriptions. It's just not possible. Now, maybe there are some pharmacies now who are trying to do that without playing with the PBMs, the cost plus route and the cash only pharmacies, which certainly is promising. And I've spoken to some of the owners doing that. But in general, if you want to fill prescriptions with people using insurance, you cannot survive as a pharmacy doing only that. You have to come up with some source of revenue, whether it's services, whether it's a membership, or like I'm doing here, products, our own or other products. And I think we're a great representation of a pharmacy who's dipping their toes into a million different ways to figure it out. And just as you're fascinated by talking to multiple pharmacists, I love talking to other pharmacy owners as well and figuring out what they have done to squeeze that little bit of revenue out that they're not getting anymore from just copays.
Yeah, I love it. Alec, so we're going to shift gears and get into something called the Drugstore Cowboy, which is fascinating to me. And it's a whole advocacy and mission. It's part of your life. But before I shift that gear, I want to go back to the clinical side and the ability to make money rather than it having to be a dispensing fee. Well, we have a partner and a client called IPC, Independent Pharmacy Cooperative, that has a platform called iCare Plus. It's a digital platform that acts as an EHR, communicates with multiple other providers, and really collects the information and then gets the pharmacy paid for. In your opinion, where do you see the value, the role of the pharmacist going? Because it's not about dispensing anymore. We're getting so close to a point in the time in history. I'm going to see it. You're going to see it. I know it's going to be in our lifetime, that dispensing is going to be not even really probably part of the intricacy and the intelligence of what a pharmacist starts to dial into pediatrics or a rare disease or blood disorder or something. So talk to us a little bit about that.
Yeah, I think pharmacists, of course, I'm biased because I am one, but I think we're the most underutilized licensed profession in America. I think, people are always shocked to find out that I have a doctorate degree and I spent 4 years to become a pharmacist, because to 90% of Americans, like, when they think pharmacist, they think the guy in the white coat at CVS, who unfortunately has to count pills himself a lot because he doesn't have the help that he needs. And I think you see in times of need when we're activated as a profession. So like the easiest example is during COVID, when we needed to all of a sudden vaccinate, millions of people, and you knew that doctors weren't going to be able to do it. Immediately, they were just like, pharmacists are trained to do that. And we were activated, and that's how the country got vaccinated. There are plenty of other situations like that for whatever reason, whether it's politics or, pride, they just won't allow pharmacists nationwide to do. I mean, I still find it ridiculous that, like, every day I have patients in my pharmacy who are out of refills on medications that they've been taking the same dose of for 10 years. And I cannot just, with my authority as a pharmacist, be like, yes, I can refill this, rather than playing phone tag with the doctor's office. I think that's a big part of it. And then there are, certain states allow pharmacists to have clinical judgment and manage disease states. So like I know in North Carolina, where I went to school, like, if you do a certain number of hours of diabetes training, then you can, help patients manage those things. Birth control is another one where, like, there's no reason a pharmacist shouldn't be able to use some regular testing to be able to help patients pick which is the correct contraceptive for them. There's plenty of ways for pharmacists to fill in gaps in the healthcare system. And I think little by little, we're getting to this breaking point where the costs are becoming so high that eventually we're going to have no choice but to allow pharmacists to do these things. And the real question for the pharmacy owners is, when that happens, are you all of a sudden going to be scrambling to figure out how to capitalize on it? Or are you already thinking about it now and figuring out how to set yourself up? With the compounding boom that just happened, you saw how quickly the winners were sort of determined. The second there was this space allowed for it, all of a sudden, there were 5 or 6 winners, and everybody else is kind of left trying to figure out what the next thing is going to be. I always try to advise these other pharmacy owners I talk to, like, when the clinical service things happens, we're not going to get 3 years of warning for you to prepare for it. All of a sudden that switch is going to be turned on, and either you're going to be the winner or somebody else is. Make sure that you're thinking about this in advance.
Absolutely. We just welcomed the Alliance for Pharmacy Compounding, which is our leading association in the United States, to assure the validity, the accuracy, and the excellence of pharmacy compounders. Very proud to have them on the network. And I'm proud to hear that you guys are, into compounding. Are you doing sterile or non-sterile or a combination?
So it's complicated for us because we're a landmarked business and a landmark building in New York City, which means that the New York City government has deemed us historically significant and the building itself historically significant. We are not allowed to adjust anything. If you come to Bigelow, and I think you probably saw on the website, like, it looks like it did 100 years ago, which is something that's super cool about it. But unfortunately, a couple years ago, when USP standards changed, and in order to do certain compounding, you had to meet USP 800 and have like a sterile compounding hood. Because we can't adjust our building, we can't do that anymore. So we used to do a lot of hormones and things like that, but now we basically do a lot of the hemorrhoid creams, nifedipine, diltiazem, and we do a lot of low-dose naltrexone capsules. But we cannot do any sterile compounding anymore, unfortunately. I have, we can transition through this comment to Drugstore Cowboy. I've been pretty vocal about the whole compounding world. And I see lots of, I don't know if you had Scott Brunner, the CEO of the compounding organization, on here, but I see him posting on LinkedIn all the time about it. And I have mixed feelings about compounding, because on the one hand, I think, just like I said, pharmacists are capable of way more than we're doing. Like, I fully believe that myself and all the people who have trained as pharmacists are capable of making safe medications, and that's another example of filling in the gaps when there's a shortage. Who do we activate? We activate the pharmacists. On the other hand, and I've talked about this in Drugstore Cowboy, I am all about the advancement of medicine as a whole. And unfortunately, the way that our healthcare system is set up, uh, pharma companies need to make money with the drug patents and the drugs they invent in order to invest more into research and development. And part of me worries that we're about to eradicate the entire drug patent system. And I don't know where the advancement of medicine is going to come from at that point. And not that I have the answers to any of these questions, but these are just things that I think about out loud on my newsletter, Drugstore Cowboy, that we can discuss a little bit about.
Well, let's get to that. I was really fascinated by the newsletter. I'd like to encourage all of our listeners to take a look. Just go to drugstorecowboy.com. Once again, that's drugstorecowboy.com. There'll be a link in the show notes to take you here. Talk to us about this newsletter and your dedication to this, because this can become, I mean, you're talking to a guy that had a full-time job for the first 10 years of running a podcast network. And then I had to come home and put a bunch of podcasts together by myself before I guess we're in the big leagues now, but
yeah, so you know what it's like to have a weekly and more than weekly homework assignment for yourself that you created out of thin air. So Drugstore Cowboy, yeah. So for the past, I would say, let's start with about a year ago. I, just like many of the pharmacists I'm sure you speak to, had felt about as beaten down as I ever had by the PBM life and fighting with them on audits and reimbursements. And this was during the rise of GLP-1s. The real takeoff of them. And I'm in the West Village in New York City. This is, where Sex and the City was based. My customers are A-list celebrities and wealthy people. So I probably fill more GLPs than 90% of the pharmacies in America. And we were just hemorrhaging money. And I was really feeling beaten down. And then I listened to a podcast with Mark Cuban. And he said extremely confidently that he fully believes that we will rebuild the system in our lifetime in a way that's favorable to patients and pharmacies. And it just got me, it like reignited something in me. And I sort of was like, I need to figure out a way to make a difference here. I'm not going to start my own drug company like he did, but I said to myself, I do have a platform. I have this qualifier that I run the oldest pharmacy in America in the biggest city in America. And that I had a great pharmacy education. So I spent the next few months kind of figuring out what I wanted to do with that. And one of the things that stood out to me is that I believe Bigelow's has one of the brightest and most successful customer bases of any pharmacy in America, just based on where we are. We take care of all, the Wall Street people, all the writers for the New York Times and the magazine editors. And a common theme to me is that as smart as and successful as these people are, none of them understand anything about their healthcare whatsoever. Like, I would have to explain things as basic as what a copay and a prior authorization is and why I don't come up with the price that you have to pay. And I was just like, if these people don't understand what their healthcare is, then how does anybody in America? And we live in the most politically active time that I can remember in my life right now or in history. And people are angrier at healthcare than they ever have been. They care a ton about it. Look how many shows there were about the opioid epidemic and, people protesting about Medicare and Obamacare and everything. And I was like, so the interest is there, but if we want anything to change, then people really need to understand how everything works and what actually is going on behind the scenes. And I didn't think that anybody was explaining that to the common man. I think there's fantastic journalism made for people like you and me who live and breathe this stuff every day, and pharmacy owners, but we're just a small group of people. If you want anything to really change politically in this country with policy, you need the masses involved and you need them to get what's going on. So I said, I want to fill in that gap, almost like pharma for dummies. I hate saying that because I don't want to make it seem like it's not for smart people, but like, I was like, if in 5 minutes a week, I could teach all these people little bits and pieces of what even a PBM is. I mean, how many people in your life have no idea what a PBM is? Arguably, they're the companies that are affecting Americans more than anyone else in the world. And I just said to myself, all right, every day I'm already doing this. I'm explaining to smart people in simpler terms what, you know, a copay is, how it was determined, what a PBM is. And I just said, why don't I try to take that and put it into a newsletter format and expand my reach? And you know, you'll see my newsletter is free. I asked for your email address just because I want it to go to your inbox, but I don't charge for it. I don't plan on charging for it. I don't plan on monetizing it. It's just about, I actually think, like Mark Cuban said, we have a chance to change these things that I'm very passionate about in our lifetimes here. But the only way to do that is to make sure that people really get what's going on, and I'm trying to do my part. So I tried to make it fun, and you know, you could tell from the branding and the imagery, Drugstore Cowboy is a callback to a very popular movie from the 90s. And I just said once a week I'm going to try to pick one topic, whether it's news, whether it's an explainer, whether it's my thoughts on compounding, and just teach people about the things that they don't know. And I think it's really started to connect with people, to the point where even Mark Cuban himself, a week ago, coming full circle, tweeted a link to my article, my PBM explainer, and said, "This is a great explainer of PBMs. Everybody should read this." So it's been a really exciting homework assignment, as I put it before.
Incredible. Incredible. You heard it here. You heard it here on TWIRx. Drugstore Cowboy, drugstorecowboy.com. I will once again have a link in the show notes. We have to have you back. If I get up to New York, I come up to meet the RX Insider team. They're in Rhode Island, not that far away. Got to schedule some time and come see this store, take some photos, and get some good sushi or something with you sometime.
Yeah. We've been here for 187 years in the same spot. So no matter when you come back, I promise you, we'll still be around and you'll know where to find us.
Alec, this has been tremendous. Thank you so much for being on TWIRx and spending time with me.
Thanks for having me. Appreciate it.
All right.